Welcome, everybody. We will begin the presentation in 2 minutes. And welcome to those who are just joining. We will begin the presentation in 1 minute. Okay, in the interest of time, we'll get started. Hi, everyone, and welcome to the National Leukemia Conference. This is the 3rd year of the conference, and we are pleased to be able to offer this year's event in a virtual format for the first time ever. Thank you for adapting with us and joining us today. Throughout the week, we will be sharing educational tools on leukemia and stories of hope. We also have 2 more presentations scheduled tomorrow on CML and CLL. In today's presentation, we will learn more on treatment options and what you can do to minimize the impact and side effects of cancer treatment for AML. My name is Indrik Kopal, and I'm the Manager of Advocacy and Partnerships at the Leukemia and Lymphoma Society of Canada. I will be the moderator of this online event. If you're joining us for the first time, welcome. And if you're joining us for a second or third time, welcome back, and please bear with me while we go through a few housekeeping items. I would like to take this opportunity to direct you to the question box of your GoToWebinar panel. We encourage you to type your questions and comments in the question box at any point during the presentation. The presentation should last approximately 60 minutes, including a question and answer period. I will ask Dr. Chan some of your questions during the question and answer period at the end of the presentation. Due to the number of questions, we may not be able to answer all of them today. If your question is not answered, we will do our best to follow up with you outside of the presentation. The conference is being recorded, therefore you can listen to it again on our website. We will email you when everything is available. Simply put, at the LLSC, our mission is to cure blood cancers and improve the quality of life of all Canadians affected by a blood cancer and their families. Ultimately, we are here to serve you. We offer support and guidance to people affected by blood cancers at every step of the way. Please don't hesitate to contact our local community service managers to find out how we can help. We offer a variety of educational resources and support services to help those affected by blood cancer. On our website, bloodcancers.ca, you can access a number of free information booklets and fact sheets about blood cancers, treatments, and psychosocial aspects of your journey. We also have various educational videos to help you fully understand blood cancers and treatment management. On our website, you will also find the recordings of all of our past webcasts and announcements of upcoming LLSC webcasts. We encourage you to subscribe and listen to our podcast series, The Blood Cancer Experience, to learn more about treatments and research from experts and to hear stories from people affected by a blood cancer. Our podcasts are available on Spotify, Apple Podcasts, and anywhere you enjoy listening to your podcasts. We recognize that sometimes it's best to connect with someone who has been there before. Our peer support program is a support service that matches people affected by blood cancers, caregivers, and their families with trained volunteers who have been touched firsthand by a blood cancer and have shared similar experiences. It can be a supportive program, which is especially relevant today during COVID, where we hope it will counter the effects of isolation. We are proud to share that in June 2020, we launched our Your Life After Cancer program. We know that the transformation from treatment to post-treatment isn't easy, and we know that every cancer experience is unique and every step has a deeply personal meaning. This program offers tools and resources to help you move forward after your blood cancer experience. We encourage you to visit yourlifeaftercancer.ca to view our new fact sheets on important topics such as fatigue, cognitive issues, and how to support a loved one. You will also find webcast and podcast recordings along with inspiring stories from survivors. It is my pleasure to introduce our speaker, Dr. Stephen Chan. Dr. Chan is a clinician, scientist, and staff physician at Princess Margaret Cancer Centre in Toronto. He is also an assistant professor in the Department of Medicine at the University of Toronto. He received his medical and research training at Stanford University in California, where he earned his MD and PhD degree in immunology. He completed his internal medicine residency and adult hematology fellowship at Stanford University Stanford Hospital and Clinics. He conducted his postdoctoral research under the supervision of Dr. Ravindra Majeti at the Stanford Cancer Institute with a focus on mitochondrial function in AML. Dr. Chan started his independent laboratory at Princess Margaret Cancer Centre in November of 2015. His current research focuses on 1, understanding the role of mitochondria in leukemia development, 2, developing novel therapeutic approaches that target metabolic and mitochondrial pathways in leukemic stem cells and pre-leukemia, and 3, overcoming resistance to targeted therapies in AML. Welcome, and over to you, Dr. Chan.
Great. Thank you for the introduction. And I want to first thank everyone for joining me today to learn more about acute myeloid leukemia. As Inkel mentioned, I've been at Princess Margaret now for about 5 years, and the focus of my clinical work has been the treatment and management of patients with acute leukemia. And a substantial portion of those patients have acute myeloid leukemia. And what I really would like to do today is to address some of the most frequently asked questions when patients are diagnosed with the disease, and also along the treatment course and the journey through treatment phase. So before I address these top 10 frequently asked questions, I just want to mention a few things that I have learned over the years with regards to managing your thoughts and your approach to the treatment phase of acute myeloid leukemia. And the reason why I want to talk about this is because when you're first diagnosed with acute myeloid leukemia, it can be a very daunting experience, and you are thrown with all kinds of information about the disease and ways to treat the disease, and it can be very overwhelming, especially on that first day when you're first told the diagnosis. And I understand that, and I think the best way to really think about the treatment of AML is to really tackle it one step at a time, and not focus so much on the ultimate goal. While that's important, it can at times be very overwhelming, and I think for a lot of patients, it's most important to focus on what the next step is and achieving that next step. I think it's also very important to emphasize that each patient takes a different path to success. There are some patients who have a relatively smooth course towards what success is for that particular patient. However, there are other patients, I would say the vast majority of patients go through a much more convoluted course with ups and downs in their treatment, and that's okay, and that is something to be expected. And you should not compare your path with someone else's path, and each path is unique, and it's very important that you think about that and you work with your physicians to get to where you want to be. And then very lastly, I just want to mention that each patient has a different meaning of success, and what is success to you is going to be different than the what success means to someone else. Success could mean cure, getting rid of your disease completely. For some patients, it may mean stabilizing the disease. For other patients, it may mean maximizing their quality of life. And for others, and I get this a lot, where patients tell me they really just want to attend important life events for themselves or for a loved one. So it's very important for you to tell your physicians what success means to you, and how you want to get there. Of course, these are not mutually exclusive. You can try to have achieve many of these points at the same time. And again, it's very important for you to discuss with your doctor, to discuss what's realistic and what's most important to you. All right, so with that said, I'm going to jump straight into the first question. So what actually causes acute myeloid leukemia? And this is a question that I get quite frequently from my patients, especially when they're first diagnosed. We actually know quite a bit about the underlying changes that cause the leukemia cells to arise initially. So AML is caused by changes in the genetic code of what are known as blood stem cells. Okay, and these blood stem cells are the ones that give rise to all the other blood cells that that you may read about in your blood reports. So these are your white blood cells, your platelets, and your red blood cells. When the blood stem cell accumulates or acquire about 3 to 4 different mutations at very specific sites in the genetic code, that's usually sufficient to make that normal blood stem cell and make it into a leukemia stem cell. And that's when they are essentially stuck at a stage in development known as a myeloblast, or sometimes we simply call them blast for short. So when your physicians talk about these blasts in your bone marrow or in your blood, they're referring to these leukemia cells that are essentially stuck at a particular stage in the maturation. And when these leukemia blast cells accumulate to high levels in your bone marrow, they prevent your normal blood cells, which are still there, from maturing properly. So how are those mutations, how did they get there in the first place? We now know that these mutations are acquired in a stepwise fashion. So the cell may acquire the first mutation 10 years ago. That first mutation does not make that mutated cell into a leukemia yet. Most of the time, those cells function more or less like normal. However, they continue to survive and they continue to divide and make more versions of themselves. Now they are primed to get a second hit or a second mutation, and now they're even a little bit more closer to becoming a frank leukemia cell. And by the time they get to about the third or fourth mutation, they have everything that they need now to become a full-fledged cancer cell or a leukemia cell. And this is very similar to what happens in other types of cancers as well, like colon cancer, where we know that it requires a number of mutations to happen in a stepwise fashion in order for your normal cells to eventually become a cancer cell. And it's interesting that many of these sort of first mutations can happen many years before AML actually shows up and patients show up to my clinic. Now, the fact that these mutations occur many years before the leukemia develops actually opens up an opportunity for intervention. Now, we don't have the capacity yet to actually intervene and actually change the course of the disease, but we're getting close. And this is actually one area of research that I am working on in my lab right now to try to figure out ways to prevent these early mutations from progressing further and becoming leukemia many years later down the road. So this still does not address the question regarding where these genetic changes or mutations came from. There are a number of causes that we are aware of, and the first one is simply copying errors. So each, if you can imagine, in each cell of your body, there's a book of instructions with DNA that contains 3 billion characters. Okay, so 3 billion letters there are in this book of instructions, and each time that cell makes another copy of itself, the cell needs to copy that book of instructions 3 billion times for each character. And as you can imagine, you know, even for a process that's pretty much close to perfect, but it's not 100%. So every time that happens, a small change occurs in that book of instructions, and over time and with many cell divisions, then you get accumulation of errors. And if these errors happen to occur at very specific locations along your genetic material, that's when it leads to cancer cells and the leukemia cells. We also know that exposure to prior chemotherapy or radiation can also lead to these genetic changes. The reason why chemotherapy works and radiation works is indeed through damage to the DNA. And so the idea there is we generate so much damage to the DNA, to the genetic material of the cancer cells, so that they cannot divide and make more copies of themselves, and then they eventually die as a result. However, as a side effects of that, the chemotherapy and the radiation also does the same thing to the normal cells in the body. And if those damages are not fixed and the cell continues to survive, then those DNA damage can then lead to mutations that make that cell now more susceptible to forming a cancer or a leukemia later on. So this is a known risk factor for AML, and this usually occurs in patients who received chemotherapy or radiation for another type of cancer, for example, breast cancer. Now, finally, there are cases of AML where the first initial genetic changes that predispose you to having leukemia later on is inherited. And we know that because there are families with a very strong history of having leukemia or similar types of cancers. So I'm going to spend a little bit more time and talk about the inherited causes of AML. And this is, again, a question that I get asked quite often, and for good reasons. I think a lot of my patients want to know whether this is something that he or she can pass on to their children. So in some cases, yes. I would say that in the vast majority of cases, this is their AML is not inherited, but in a smaller percentage, that is indeed the case. How frequently that is, it's still unknown, but the estimate is about 15% of cases. Okay, so it's not a small percentage. I think we're becoming increasingly aware that maybe these AML cases are inherited in more frequently than we used to think. We now know to a greater degree what these mutations are and at what locations and what genes are affected. And again, these we usually have a suspicion that AML is inherited when there's a strong family history of cancers. Usually it's related types of cancers, of blood cancers, but it can also happen in families where there's a strong family history of solid cancers as well. So for example, things like breast cancers and colon cancer. We are also suspicious of inherited cases of AML when the onset of the cancer or leukemia is early. Usually AML cases that arises later in life, those cases we tend to think are more likely to be due to mutations that are acquired during the life of the patient. However, for patients who have an earlier onset of cancer, then that's when we suspect that maybe there's something in the DNA, in the genetic material there already that predisposed them to forming leukemia earlier on. And then in some rare circumstances, there are other findings that make us suspicious of an inherited case of AML. For example, I don't have the time to go through all these other changes, but I just want to point out that for some familial cases of AML, we can patients also have other signs such as deafness and also changes in their nails. So those are changes that when we see or hear about during our physical examination may make us think about, hey, this may be an inherited case of AML. So how do we confirm this? Well, we need to look for the presence of mutations, the mutations that are passed on from the parents. The most common ones are the ones listed here. And these genes are usually, if at least at Princess Margaret, tested for the presence of these mutations. However, to be absolutely sure that this is what we call a germline mutation, or a mutation that's actually inherited from your parents, we need to do more specialized testing, and it may require referral to a specialist who analyze and look after patients with inherited forms of cancer. So that this kind of specialized testing goes beyond just looking for mutations in the leukemia cells. Sometimes we need to start looking for the presence of these mutations in other parts of the body. And the most common part that we typically look for is in the skin sample. So you need to do a skin biopsy, and we take that sample and we try to grow out the cells in that skin biopsy, and then look for mutations there to see if the mutation is actually in the skin as well. If the mutation is in the skin and in the leukemia, that's fairly strong evidence that this is something that the mutation is inherited from the parents. Why is this information important? It's important in some cases because it changes the decision as to whether or not to go for a bone marrow transplant. For some patients, the leukemia might be treated, it might be gone, but because that mutation is inherited, the cells are still there and they are at risk of having another leukemia later on in their lives. So a bone marrow transplant to really just replace the whole blood system, to remove that mutation in the blood system may make sense in those patients. It also affects the selection of potential donors for bone marrow transplant because these mutations are inherited. It may pass on to siblings of the patient. And we want to check if that mutation is also present in the sibling, because if it is, then that sibling is probably not the best donor for the patient. It's also important even in settings where a bone marrow transplant is not being considered, because those family members should get tested for the mutation and should be monitored for the presence of potentially a blood cancer. And right now, there's no firm guidelines as far as what needs to be done. There are some guidelines that says that maybe you should do a bone marrow biopsy if the mutation is present for those affected family members. However, that's not entirely clear, and it's not entirely clear how often you should check for the presence of blood cancers as well in the family members. But nevertheless, I do think it's important to know who the family members are who are affected so that they can be monitored by physicians. And then, of course, there's the potential risk of transmission to future generations. And this is something that needs to be discussed with your leukemia doctors. All right, so on to the third question. And so how is AML currently treated? So I'll talk about this first before I talk about some of the newer novel therapies that are becoming available for patients in Canada. So traditionally, we think about treatments in sort of a spectrum. You have at the one end of the spectrum, you have high intensity chemotherapy, and this is the kind of therapy that you think about when patients are treated for cancer. You're in the hospital, you receive chemotherapy through your veins. And you lose your hair, and you have other toxicities associated with the high intensity chemotherapy. We definitely continue to do this for a lot of our patients. And the goal here a lot of times is to achieve a cure of the disease. At the other end of the spectrum, we have what we term best supportive care, and that's primarily blood transfusions, platelet transfusions if needed, and antibiotics to treat any infections that you may have. And that's but nothing really directed against the leukemia itself. We have patients that choose best supportive care because that really maintains the quality of life. So you're not in the hospital all the time. You're not going through the side effects of the high intensity chemotherapy. And we're really trying our best to maintain that quality of life for as long as possible by supporting you. Now, there are a growing number of treatments that fall under sort of this lower intensity chemotherapy or treatments. And this is the goal there a lot of times is to stabilize the disease. So you are doing something to target the leukemia, trying to keep it under control. But you're doing less intensely than sort of the conventional high intensity chemotherapy, but you're doing more than just giving that supportive care. And a lot of our patients, as you can imagine, are actually choosing this type of treatments for their disease, as long as it's consistent again with what their goals are. And I can also mention that a lot of these lower intensity treatments now are not simply just stabilizing the disease anymore. And I think that one of the emerging themes from the latest, most recent research is that these therapies can potentially lead to cures as well without all the side effects that are associated with high intensity chemotherapies. And I'll talk a little bit about that in the subsequent slides. So this is a diagram showing how AML is currently treated. We have patients that are, when they're initially diagnosed, and without really a lot of thought that goes into it, we might prescribe induction chemotherapy. And some of you may have heard of this term 3+7. That's 3 days of a drug called daunorubicin plus 7 days of a drug called cytarabine. And that has been the standard for over 30 years. And this is what we do. And for good reasons, because it works for up to 70% of our patients, and we can get them into what is known as a remission. And I'll talk about what we really mean by that in the subsequent slides. Now, during this period when we're giving the induction chemotherapy, we're actually doing a number of tests in the background to really try to figure out your risk category. And the reason why that's important is once you get into a remission, we have to decide whether more chemotherapy alone is sufficient to potentially get you into a cure, or do we think that you require a bone marrow transplant to get you into a curative state? The decision is primarily based on your risk group. If you're low risk, so a low risk of relapse, for example, then we think that more chemotherapy may be sufficient. For those who are higher risk disease, then we recommend a bone marrow transplant. The way that we determine whether you are low risk or high risk is by doing a number of tests on the cells that are collected, leukemia cells that are collected at the time of diagnosis. And many of you may be very familiar with this. We look at things like the cytogenetics. This is actually how the DNA looks under microscope. And we also test for other mutations that are much harder to look at. They're at the molecular level, and those are in the genes called FLT3 and NPM1. And now we're actually testing for a much larger panel of mutations in other genes as well that together come together and tell us a much more comprehensive picture as far as your risk group. Now, it's important to realize that currently, once you're done with consolidation or bone marrow transplant, your anti-leukemia treatment essentially stops there. Okay, we don't necessarily give you more treatment, and we monitor you very closely for signs of relapse. Okay, so this is how things are currently done, and I have to say within the last, I would say 3 to 4 years, our landscape, our strategies for how we treat patients have completely changed, and it's going to change, I think, for years to come as more newer medications come on board, and as we learn how to use these new medications to more effectively treat our AML patients. So let's talk about some of the new drugs that are currently available for acute myeloid leukemia. So I'm not even going to be talking about the ones that are under development. These are the ones that are approved and available for use today. Okay, so over just the last 3 years, we have an approval for 8 different new drugs for AML after a period of about 30-40 years without any new drugs coming on for this disease. So it's a very exciting time for physicians like myself who now have a lot more drugs available to help my patients. Now, it does make things a lot more complicated, and I'll talk about that in the subsequent slides. So I'm going to, in the next few slides, I'll spend a few minutes to highlight some of them and tell you about what you can expect from these drugs and how they are used. Again, I'm not going to go through a lot of data. This is not a data heavy session, but I really want to just let you know what these drugs are so that you can bring this information and ask your treating physicians whether or not this is potentially something that would be suitable for you. So the first class of medications are what are known as FLT3 inhibitors. FLT3 is a gene that encodes a protein that's on the surface of the leukemia cells. Mutations in this FLT3 gene makes this sort of protein with this receptor always activated, and it basically sends a signal to the leukemia cells to say, let's keep proliferating, let's keep growing without control. Okay, so what FLT3 inhibitors do is, I think you probably figured this out, is to stop this signal from continually activating that leukemia cell to grow and stop telling the cell to just keep proliferating. There are 2 drugs currently that are available for inhibiting FLT3. The first one is called midostaurin, and that's the generic name, and the trade name is Rydapt. This drug is currently used in the setting of newly diagnosed FLT3 mutated leukemia patients, and this is given in conjunction with conventional chemotherapy. So for example, 3+7 induction chemotherapy, or later on with cytarabine consolidation chemotherapy. It's never used as a single agent by itself, and this agent has shown a survival benefit for acute myeloid leukemia patients. Before I go on, I just want to point out one thing. I don't want to give out numbers in this talk. I think if this is something that interests you, I advise you to talk to your doctors about what the survival benefit is, if this is something that you're interested in. And the reason why I'm not doing that is because that number depends on a lot of factors, and I don't want to give a number that may not be applicable to your specific case. The next drug I want to talk about is called gilteritinib. This is another FLT3 inhibitor. However, this drug is used in a slightly different setting. This drug is currently approved for patients with relapse or refractory acute myeloid leukemia that carries the mutation. This drug, in contrast to midostaurin, is used alone, and it has been shown to increase your rate of remission compared with chemotherapy and it also increases the survival of patients who are in this drug, again, compared with chemotherapy. The next class of medications I want to talk about are what are known as IDH inhibitors. IDH is a gene known as isocitrate dehydrogenase. It encodes a protein that, when mutated, can drive and promote the development of acute myeloid leukemia. And by inhibiting the function of this protein, we can actually get these cells to regress, and these leukemia cells actually then, I don't know if you remember from my earlier slides about how these cells are stuck in a particular stage in maturation. What these inhibitors do is to allow them to sort of release that brake and allows them to continue to mature like they should normally. There are two drugs under this category. The first one is called ivosidenib, and this drug is used in the setting for relapse or refractory leukemia patients that carry the IDH1 mutation. So there are actually multiple forms of this gene. There's IDH1, IDH2, and there's IDH3 as well. But mutations are only present in IDH1 and IDH2, and we now have drugs actually for both of them. Ivosidenib, again, is only for the IDH1 mutated form of AML. This drug is used alone, and it can, well, despite the fact that I am not going to give you numbers, I am showing you some numbers here. The remission rate can be around 40 to 60%. The other drug is called enasidenib. This drug is for IDH2 mutated AML. It is also used alone, and it can generate remissions in about 40 to 50% of patients. There are another class of drugs that target proteins that are important for AML survival. So the difference between these drugs as compared with the drugs that I talked to previously is that they don't necessarily target a specific mutation. They target proteins and pathways that are important for the survival of all types of leukemia cells. The first one is called glasdegib. This drug was just recently approved in the US, and it's now available in Canada. This drug is meant for use in newly diagnosed AML patients over the age of 75, or those who cannot tolerate high-dose chemotherapy. This drug is given in combination with another chemotherapy drug, but at a lower dose, known as cytarabine, and this drug has been shown to improve the likelihood of getting into remission and also improve survival compared to those who just have cytarabine or chemotherapy alone. The next one is called gemtuzumab. This is actually a very interesting drug. This is an antibody, so in some ways it's sort of taking advantage of your immune system to fight this disease. And this drug is used to treat newly diagnosed AML patients with this marker called CD33 that are present on the surface of the leukemia cells. This drug is given in combination with conventional chemotherapy like 3+7, and it too has been shown to improve the survival of patients with better risk disease. Now, I want to end by talking about what has become a favorite drug, a fairly commonly used drug for a lot of leukemia physicians in the United States and in Canada. And that drug is called Venetoclax. Some of you may have heard of this drug. This is really a drug that I think it's going to change how we treat AML in many years to come. This drug, Venetoclax, works by a very unique mechanism, very much unlike anything that we have had before. And this is what is known as a first-in-class inhibitor of a protein called BCL2. BCL2 is a very interesting protein. It essentially, it's there, and its sole purpose is to keep the cell alive, okay? And this is present in normal cells as well, but for reasons that are still unclear to us, cancer cells, and especially leukemia cells, are highly dependent on this protein to keep themselves alive. Whereas normal cells, while they're still dependent on them, they're a little bit less dependent. And because of this difference in dependency, we can actually take advantage of that by using this drug that inhibits this BCL2 protein. And when we treat leukemia cells with this drug, we essentially remove this inhibitor of cell death, and the cell undergoes cell death. What we know is that using this one drug alone, a lot of times it works for a little while, but it doesn't work that well. And the most recent studies have used it in combination with a drug called azacitidine or Vidaza. The combination, it is a combination of these two drugs that appears to be the key to a successful treatment. So I'm not going to show you a lot of data in this presentation, but I do want to show you one because I think this is very, very, very important. This set of data just came out several months ago. And what you're looking at is your survival curves of AML patients over time. So on the bottom, you have time from the time of diagnosis. And then on the y-axis, that's the percentage of patients that are still alive over that time period. This clinical trial was conducted in patients who were previously untreated, so they're newly diagnosed. Patients who are eligible for the study if they were over the age of 75, or if they are deemed not eligible for high-intensity chemotherapy by the treating physician. And then patients were randomized to receive the azacitidine drug or Vidaza alone, or Vidaza plus Venetoclax. And they were recruited over 400 patients on the study. As you can see, there is a greater percentage of patients that are alive at 12 months and 24 months from the time of diagnosis. Now, what excites me the most about this graph is the fact that if you look at those who are treated with azacitidine plus Venetoclax, that line plateaus. So that means that there are about 30 to 40% of patients that are potentially cured with this regimen alone. Okay, so that's a very important point. This is an oral drug plus an injection in previously untreated patients, and we can cure these patients. So this is very intriguing, and I think we need to do better. But the fact that we can take something that's basically relatively low intensity and get a curative treatment is very, very intriguing. And I think it's very promising. And as you can imagine, there's a lot of excitement going on now to try to make this combination even better by adding a third agent onto this combination. So again, very quickly, Venetoclax is currently about to say it's actually approved in the United States, not yet approved in Canada for use in AML patients yet, but we do have access to it through other channels. It is used currently approved in the setting of newly diagnosed AML patients for those who are over 75 or cannot tolerate chemotherapy. However, I do have to say a lot of us are now using this drug in the setting of relapse refractory disease as well. The results are not as good as what you just saw previously in the previous slide, but they are still pretty good, and we're using, and I have seen quite impressive results with this combination. This treatment again has been shown to increase the rate of remission and also survival as well. And I firmly believe that this combination venetoclax plus azacitidine will be this sort of this next 3+7 chemotherapy that we have been using for the past 30-40 years. So as I mentioned to you earlier, we as leukemia physicians, we welcome the having 8 different new medications that we can use to help our patients, but it does actually make things a lot more complicated, because now we have to consider the mutations that the patients have, and then use the most appropriate drugs for that specific type of leukemia. Whereas before, everyone got 3+7 chemotherapy. It wasn't that hard, but now it's a lot more complicated. And to be completely frank with you, a lot of us don't know exactly what the best treatment should be. For example, a patient who has an IDH mutation. Well, it might make sense to use an IDH inhibitor, but data has also shown that venetoclax plus azacitidine also works very well for that subgroup of patients. So should we do the IDH inhibitor first, or should we do the venetoclax approach? This is something that we are continuing to learn and do more studies to figure out what the best approach is. But I do want to point out a very important trial that are close to completion, and this is a trial known as the BEAT AML clinical trial that involves a number of sites in the United States, and this is a trial that's sponsored by the Leukemia Lymphoma Society in the US. And it's really a groundbreaking collaborative clinical trial. And what they try to do in this clinical trial is to really get a very comprehensive genomic characterization of the patient's disease before even treating them. Okay, so this is not what we currently do now. We once it's diagnosed, we send them to chemotherapy, and then we worry about sort of the subsequent treatments later. What they try to do here is to get a really comprehensive look at these are the mutations you have, and we think that these are the best treatments that you should get. And then so there's that period of 1 week where we don't do anything except to wait and get the results of these genetic tests. And I think that this approach, if the patients are stable enough to wait that 1 week, this is the approach that we should be taking going forward. And this is something that you should ask your doctors about in terms of doing a comprehensive genetic testing if that's available at your center. All right. So question number 5. A lot of my patients have asked me about CAR T cells, and this is something that's very commonly, very frequently spoken about in the press. There's a lot of press about CAR T cells and how amazing they are, and indeed they are very amazing. And CAR T cells are currently now available for treatment of a number of B cell cancers, for example, with B cell ALL, B cell acute leukemias, and certain types of B cell lymphomas. However, this treatment is not yet available for AML. There's a lot of interest in developing CAR T cells for AML, but they are very early in their experimental stages, and they're not even in clinical trials yet. But hopefully they won't someday, and we will have one additional drug that can help fight acute myeloid leukemia. So question number 6, how much leukemia is actually left in my body after initial treatment or after consolidation chemotherapy? How much is actually left, and then how do we measure that? So this is what I'm showing you is a graph showing you the amount of leukemia or tumor that's in your body at different phases of your treatment. Um, there is a big drop in the amount of leukemia cells after induction chemotherapy, and that gets you into what we call a cytological or morphologic remission, and I'll talk about what that means a little bit later. But to get to that phase, to get to that stage, it's actually not that difficult. We just really need to decrease your number from where you're starting off by about 95%. So you still have a lot of leukemia cells, despite the fact that you are in what we call a remission. And that's why we tell our patients we cannot stop there. If we just stop there and not continue to treat you, the leukemia will come back. The goal of consolidation chemotherapy or maintenance therapy, which I'll talk about a little bit later, is to get you into what we call a deeper remission, to reduce that level of what we call minimal or measurable residual disease to as low as we possibly can. And perhaps not surprisingly, those who have higher levels of residual disease are most likely to relapse, have a frank relapse of disease. And those who have very low or undetectable levels of measurable residual disease, those are the patients who typically do the best. But the trick is to find that one leukemia cell out of sometimes a million healthy cells, and that's the challenge. That's equivalent to finding really a needle in a haystack. So how do we actually do this? So conventionally, we look at it under a microscope. So as you can imagine, so the pathologist would get a sample from your bone marrow. A pathologist will look at your sample under the slide, and they'll count maybe 200 cells, maybe sometimes 500 cells under the microscope. And at that level of sensitivity, at best, we can say there's one leukemia cell in about 20. So it's not very good, but that is really the definition of remission for many of us. So that's clearly not good enough. So what we are currently doing at Princess Margaret is to use a technology known as flow cytometry, and this is a very cool technology that's been around for many years now. But it essentially takes your blood sample or your bone marrow sample and then runs it through this machine, and using a laser, it can actually determine whether each cell is normal cell or is a cancer cell, and it simply counts, and it does exactly that, and it can count can count and identify about one leukemia cell in about 1,000 normal cells, and that's about the level of sensitivity. It's good, much better than microscopy, but still not good enough. So what we are really trying to do now is to use genetic methods to look for that specific mutation that's present in your specific leukemia. So, and that's another reason why it's so important to know the genetics, the mutations that are present in your leukemia, because that will not only allow us to determine what your best therapy is, it will also allow us to come up with methods to best detect your leukemia at a very highly sensitive way. So using these methods, we can sometimes detect it down to 1 in a million cells. So that's equivalent to finding, the 2 leukemia cells in 2 people in a population of Toronto, for example. So it's a very highly sensitive test. These tests are still undergoing testing at Princess Margaret, but hopefully this is something that we can actually bring on board in the coming near future. So are there medications to help keep me in remission once I am in remission? So the answer is yes. There is a medication that is now approved in September, just a few months ago, in the United States. It's not yet in Canada. Usually it lags behind by sometimes months to maybe a year or two. So hopefully it'll be here soon. But we now have this medication that can potentially help these patients keep them in remission. The drug is called oral azacitidine. So it's actually the same drug that you heard about earlier, that Vidaza drug that's given as an injection, but it's reformulated to a form that can be given orally and absorbed by the body. It's a once daily medication, so very easy to take. And it was tested in a randomized clinical trial involving 500 patients and who are in remission, and it showed that there was an improvement in survival of these patients. So very exciting, because this is really the only medication after many years of attempt to come up with a what we call a maintenance therapy for AML. We now finally have a drug that can be used in that setting. And as you can imagine, there are a lot of ongoing studies and clinical trials to try other combinations. So that azacitidine plus venetoclax combination that I mentioned to you earlier, that is also being tested to see if it can be used as a maintenance therapy to keep patients in remission. The other drug that I mentioned to you earlier, gilteritinib, that's also a drug that's currently being used to try to keep patients with FLT3 mutated AML, to keep those patients in remission for as long as possible. All right, so this is actually the bulk of what I'm going to talk about in terms of medications. In the last 3 questions, I'm going to touch upon something that's a little bit different, and they are still questions that I get quite often. Should I get a flu shot? I cannot, I think last couple of weeks, I think at least half of my patients ask me this question, and the answer is yes, absolutely get your flu shots. Flu shots are contain inactivated virus, so they cannot make you sick. Despite the fact that your immune system may not be functioning 100%. Now, it is important to point out that the treatments that you're getting, the chemotherapy or other treatments that you may be getting for your leukemia, may make your flu vaccine less effective. But for many, for many of you, those treatments are probably ongoing, and it's probably ongoing for many months. And you just cannot wait until the end of the flu season to get it, because or the end of your treatment to get it, because by that point the flu season will be over. So you're basically left with this whole season where you're at risk of getting the flu. So my recommendation is to get it. It may not be as effective as it would be normally, but it's still, there's some potential efficacy, and there's very little downsides to getting a flu shot. So question number 9, this is another common question that I get from my patients. What should I eat when I have leukemia? There has been no specific foods that have been shown to improve the outcomes or prevent the relapse of leukemia. Now, with that said, I always encourage my patients to maintain a healthy and balanced diet like I would for anyone else. It's important to have your fruits and vegetables and have a good source of proteins for your body. However, I should mention that foods should be fully cooked, and I think the reasons are obvious here. Your immune system is usually compromised due to leukemia and or the treatments that you're getting for the leukemia. So you really want to make sure that the foods that you're consuming does not contain high levels of bacteria. It is very important to stay well hydrated. and drink, if possible, 2 to 3 liters per day. And the reason here is that a lot of the treatments that are administered to you can be quite stressful to your kidneys, and you always want to stay well hydrated if at all possible. Vitamin supplements are generally not needed if you have a healthy, balanced diet, although if you do want to take them, they are not harmful at all. Sometimes some patients do need mineral supplements depending on what other medications they are taking. For example, if you're on a diuretic, you may need potassium supplementation. So talk to your doctors about that. And probiotics. This is probably something that that is useful and should be used more often in our patients because AML patients tend to be exposed to a lot of antibiotics during their treatments, and one of the complications of antibiotics is this thing called C. diff, Clostridium difficile infection that can cause diarrhea, and probiotics have been shown to be helpful to help prevent this side effects of antibiotics. And then very lastly, I always tell my patients it is okay to indulge in your favorite foods and your chocolate cake and whatever it is that you enjoy, as long as it is done in moderation. So very very lastly, I felt that it would be inappropriate for me to end the talk in 2020 without mentioning COVID-19 at least once. So So how has COVID-19 affected the treatment and management of AML patients? So, cancer patients have been shown to be at a higher risk of developing severe complications and death from COVID, and that's a combination of the very fact that these patients have cancer, and part of that is also because they are on treatment for the cancers that can compromise the immune system of these patients. However, despite that, delays in treatments are not recommended at this time, and that's primarily because AML is an acute disease, and this is not something that we can wait for months and months before initiating treatment. So that's why the current recommendations are to start treatment as quickly as possible still. However, it doesn't mean that it has not impacted how we treat our patients. There were a much smaller number of open clinical trials that are available to our patients back in the springtime. A number of the clinical trials have opened now, so we have more options. But my suspicion is that we're not going to be opening a lot of newer clinical trials still because of the COVID-19 pandemic. There has been an increase in, not surprisingly, virtual visits, and I think many of you who are seeing your physicians can attest to this. COVID-19 testing is now mandatory for all the patients who are admitted, and we have placed strict limitations on the number of visitors for our patients, and I completely understand that this is very stressful for both patients and family members and friends. But this is something that especially with the increasing number of cases in the community, this is something that we feel very strongly about to keep our patients as safe as possible. And unfortunately, I think due to the measures that we have put into place, the cases of COVID-19 infections in AML patients, at the very least at Princess Margaret, have fortunately been quite low. Now, I do think the ultimate solution to this pandemic problem that we are in is our vaccines for COVID-19. Hopefully, I think many of you have heard some good news about the vaccines are in development. Hopefully, they will be available for us soon. But in the meantime, I encourage everyone to stay safe, stay positive, and in the meantime, we'll continue to fight AML. So with that, I'm going to stop my talk and address any remaining questions.
Thank you very much, Dr. Chan, for sharing your time and expertise. That was very informative. It was fascinating to learn about some of the promising advancements in AML over the last 3 years. I personally really enjoyed the formatting of your presentation around some of the common questions. And in fact, you answered a number of questions that were submitted ahead of time. So that was absolutely fantastic. So, but speaking of questions, it's now time for our question and answer period. As mentioned at the start of the presentation, I invite you to ask your questions in the question box in your GoToWebinar panel. We are, in the interest of time, we may not be able to answer some of the very specific questions, but we'll certainly try to follow up with you outside of this presentation if that's the case. So we'll get right into it. So one of the questions we have here is, once a diagnosis of AML has been presented, when does treatment have to begin? Is it immediately, within days, or within weeks?
Yeah, that's a great question. So I touched on this a little bit during my talk. So conventionally, what we like to do is to admit the patient right away if we think that they are a potential candidate for high intensity chemotherapy, to bring them into hospital and start treatment right away, sometimes on the same day. But what we have been learning is that may not be necessary for a lot of our patients. We can wait, and there are medications that we can give to keep the disease stable for at least a week, if not longer. And we think that that's still potentially safe. Now, you may ask, why should we even delay treatment? And it goes back to what I was referring to with getting a really comprehensive understanding of the genetic makeup of your leukemia, so that we can assign the best treatment for your specific type of leukemia. So I think this is something that you should discuss and bring up with your treating physician and ask, should we wait a little bit and figure out what the genetic makeup is in my specific case of leukemia, and maybe that will better help us decide what the best treatment should be, rather than jumping in chemotherapy right away.
Great, thank you. We had another question too. When you spoke of early onset of AML, what age group is considered in the early onset?
Yeah, that's another great question. So the median age, so about the median age of onset of acute myeloid leukemia is about 65 years old. Okay, so 50% of patients present over the age of 65, and 50% present under the age of that. Now, obviously, we don't consider everyone that presents under the age of 64 to be early onset. I would say roughly, there's no hard cutoff, but anyone who is sort of presenting in below the age of 40, I would be a little bit more suspicious for early onset, and begin to wonder whether or not there is something else potentially going on that's inherited.
Thank you. We had a question here. With a 100% match for a stem cell transplant, and the patient is so-called cured, living a good life again, how long would you say the patient remains, in quotes, cured without remission?
Without remission? So the patient is had the transplant and it's doing well.
100%. Yep, doing well. Yep. So how long would they remain, cured without remission?
Yeah, so I think there's a very good chance that it would be for a long time, and essentially cured without the disease ever coming back.
Great.
So generally, I think I didn't talk about this during the talk, but what I typically tell my patients is that relapse usually happens within the first 2 to 3 years after completion of therapy, and if your disease hasn't relapsed and come back within that time period, your likelihood of the disease coming back later on is very, very, very low. And I never like to say cure for a lot of my patients, because we have seen patients with disease come back 8, 9, 10 years after being in remission. Those are very, very rare. I would say the vast majority of patients, if they make it past that sort of 2 to 3 year window, the chances are really good.
And we had a few questions just with connections between, so I had one person who said I had AML when I was 13 years old, then I was diagnosed with breast cancer 10 years later. Is there a connection between the two? And we've also had similar types of questions on the relation between AML and other cancers.
Yeah, so absolutely. I think there are two potential types of connections that could be happening in those cases. Number one, the treatment that you receive for your leukemia, like I said earlier, can affect the other normal cells in your body as well. So it could be your breast tissue, your colon. So they are exposed to the chemotherapy, and they have genetic changes there as well as a result of the chemotherapy. And those genetic changes can potentially make them predisposed to developing cancer later on. So that's potentially one connection. The other connection is potentially an inherited form of cancer. So there are inherited forms of cancers that make you more susceptible to developing multiple different types of cancers, including leukemia, breast cancer, colon cancer. So that's something that it's potentially what's occurring when patients present with multiple different types of cancers at the same, either at the same time or at different time points during the lifetime.
Great. And we've had some comments from people whose questions you've answered. They say, super, thank you very much, great information. So we have time for 2 more questions, and I'm going to try and bring this one together. So there's a few questions that were asked with regards to treatments, and treatments with specifically after having a stem cell transplant. So one person has asked, would the medications mentioned to keep a patient in remission be given to a patient that has had a stem cell transplant? And there's been a few related questions.
Yeah, so I think for I can't speak to your specific case without knowing the details of your disease and what kind of treatments you received. There are medications, for example, like the FLT3 inhibitors. If your disease had the FLT3 mutations, it is becoming increasingly clear that being on a FLT3 inhibitor medication post-transplant can potentially help reduce the risk of relapse later on. If you don't have the FLT3 mutation, whether or not adding something on like the azacitidine that I was talking about earlier, or Venetoclax, that's currently less well studied. But in the case of FLT3 disease, the use of those inhibitors have been shown to be potentially helpful.
Great, thank you. And last question. When you spoke of testing for mutations to consider the possibility of inherited AML, did you mean the patient of AML or the children of the patient? That is, should the children of the patient be tested for the mutations?
Yeah, great question. So the testing should start with the patient first to identify mutations that can potentially be contributing to the leukemia, and we have a fairly good understanding of what those mutations are. And the reason why you want to start with the patient first is because you need to know what you're looking for. And it's typically you need to look to find out what that mutation is, so that you need to know what to look for, so that then you can go on to test your children or your other siblings, and then those tests can be a lot more focused on that specific mutation that could be causing the problem.
Fantastic, thank you. Well, thank you everyone for your questions. And again, we apologize we couldn't get to every question, but if we didn't answer your question, an LLSC staff member will follow up with you to answer your questions.
Thank you.
And and it looks like I don't have control. Dr. Chan, would you mind advancing just to the next slide? And then we've just got a couple more slides. Great. So thank you once again, Dr. Chan, and to all of those who participated and asked questions. I would also like to thank our marquee sponsor, Astellas, and thank you to AbbVie, AstraZeneca, Bristol Myers Squibb, Celgene, Janssen, Jazz Pharmaceuticals, Novartis, Paladin, and Pfizer. And next slide, please, our last slide.
I've given you control.
Oh, have you?
Right, yeah. Or not? No?
No.
No, let me see.
Technical issues. There
we go.
Great, thank you. And before signing off, I would like to remind everyone here that we are here. If you're looking for resources or support, please do not hesitate to contact us by dialing 1-833-222-4884 or by email at canadainfo@lls.org. Please note that a short survey will be sent to all participants after this webcast. Please take a moment to provide your feedback. This will help us immensely provide us with a plan to develop more useful online events for you in the near future. I'd like to thank you again, Dr. Chan. Thank you everyone for joining us for this third leukemia conference. We hope to see you tomorrow for our conversations on CML and CLL. Have a wonderful day, everyone.
Thank you. Take care, everyone.